All right, future nurses, welcome. We are about to do a super fast, high-yield review of some of the most critical conditions you're going to see in perinatal care. We're going to connect all the dots, between pregnancy, labor, and postpartum to really sharpen your clinical judgment, not just for your exams, but for your actual patients. Okay, let's jump right in.
This quote right here, this is the heart of what we're talking about today. It's this idea of the perinatal cascade. See, what happens in pregnancy, it doesn't just stay in pregnancy. A condition like preeclampsia or gestational diabetes, it sends these ripples through every single stage of care. Understanding this continuum, it's absolutely crucial for you to anticipate risks and give safe, effective care.
So first up, we're diving into the high-pressure crises. Hypertensive disorders are one of the leading causes of mothers getting really sick or even dying worldwide. So recognizing the warning signs and knowing exactly what to do, that's a skill you just have to have. It's non-negotiable. Okay, you have got to understand this progression because things can escalate, and they can escalate fast. It can start with gestational hypertension, that's just high blood pressure, no other weird symptoms. But that can quickly spiral into preeclampsia, then preeclampsia with severe features, and then the absolute worst-case scenario, eclampsia, which is life-threatening seizures.
So what's the tipping point? How do we know when we've gone from regular preeclampsia to a severe diagnosis? Well, it all comes down to signs of organ damage. We're talking blood pressure that just skyrockets to 160/110 or higher, platelets tanking below 100,000, liver enzymes are doubling, or maybe the patient has a brand new headache that won't go away or is seeing spots. These are huge red flags, telling you the risk has just gone through the roof.
All right, let's play this out. You're with your patient who has preeclampsia, and she tells you she's got this horrible, sharp pain right here in her upper right belly. What is screaming in your head right now? What is the emergency?
That pain is a massive warning sign. It's telling you her liver is in serious trouble, that the capsule around it is stretched so tight it could actually rupture. This is a true medical emergency, and your #1 job is to get that provider now. Okay, so the ultimate crisis is happening. Your patient is seizing. This is eclampsia. In this moment of pure chaos, what are your absolute top priority nursing actions? Think fast. What do you do first?
Here is your playbook. These are the non-negotiables, in order. #1, you hit that call bell for help, and you do not leave that patient's side, ever. #2, get them on their side to protect their airway. 3, protect them from injury. Get those side rails up and padded if you can. And 4, get ready to give the go-to anticonvulsant, magnesium sulfate. These 4 steps save lives. Okay, let's shift from pressure problems to fuel system failures. Let's talk about diabetes. Pregnancy itself is like a massive metabolic stress test on the body. The demand for insulin changes like crazy, and if the pancreas can't keep up with production, we are in for some trouble.
What's so wild is how different the first half of pregnancy is from the second half. In the beginning, up to about 20 weeks, hormones actually make the body more sensitive to insulin, so the risk is actually hypoglycemia, low blood sugar. But then, in the second half, hormones from the placenta cause major insulin resistance. This is on purpose, to make sure the baby gets plenty of glucose, but it puts the mom at a super high risk for hyperglycemia. It's a total metabolic flip-flop.
So to manage all this, our targets have to be really tight. For any patient with gestational diabetes, or GDM, this is the number to burn into your brain. Their fasting blood glucose needs to be less than 95. Why fasting? Because it's our purest look at their glucose control, before food messes with the numbers. Keeping that number below 95 is everything for preventing major complications. And why does that number matter so much? Because when mom's sugar's out of control, it causes a whole cascade of problems for the baby. The baby starts making tons of its own insulin to deal with all that extra sugar. Then, after birth, that high insulin level is still there, which makes their blood sugar crash. We're talking profound hypoglycemia. It can also lead to jaundice, electrolyte issues, and even respiratory distress because all that insulin can actually stop their lungs from producing enough surfactant. Okay, let's switch gears. We're going to do a quick, rapid-fire review of a few other high-yield conditions you have to be able to spot in a second. First up, hyperemesis gravidarum. And let me be clear, this is not morning sickness. This is relentless, non-stop vomiting that causes a patient to lose at least 5% of their body weight. They're dehydrated, they're spilling ketones in their urine, and their electrolytes are a mess. Your job here is critical. You're going to be pushing IV fluids, giving antiemetics, and watching their intake and output like a hawk. And here's the lab finding that tells you just how bad the dehydration is. Hemoconcentration. Because they've lost so much fluid from their bloodstream, their hemoglobin and hematocrit are going to look falsely high. This tells you they are in a serious fluid deficit and need aggressive rehydration fast.
All right, let's move from metabolism to the immune system and talk about Rh incompatibility. This happens when you have an Rh-negative mom who's pregnant with an Rh-positive baby. During delivery, or really anytime blood could mix, her immune system sees the baby's Rh-positive cells as a foreign invader and starts making antibodies to fight them off. This sensitization usually doesn't hurt the first baby, but it puts every future Rh-positive baby in danger.
So what's the intervention? It's simple, and it's incredibly effective. We give RhoGAM. It basically works by tricking the mom's immune system so it doesn't bother making its own antibodies. We give it around 28 weeks, and then again within 72 hours of delivery if we confirm the baby is Rh positive. This one shot is what prevents sensitization and protects all of her future babies. It's a game changer.
Now, it is so easy to think that once the baby is born, the danger is over. That is a huge, dangerous mistake. Postpartum vigilance is everything because so many of these conditions are still a major threat.
Let's burn these 4 rules into your brain right now. 1. The only, and I mean only, cure for preeclampsia is delivering the placenta. 2. If your patient on magnesium sulfate becomes toxic, they're barely breathing, they've lost their reflexes. The antidote you grab is calcium gluconate. 3. For postpartum hemorrhage in a mom with high blood pressure, you never give Methergine. It's an absolute no-go. And 4. The risk of an eclamptic seizure does not end at delivery. It's still there for at least 24 to 48 hours.
And I'm going to leave you with this final thought. When the field monitor is screaming, the IV pump is beeping, and the room feels like total chaos, what is the one assessment, the one piece of the puzzle that no machine can ever give you that relies 100% on your brain and your clinical judgment? Mastering that, that is what's going to make you a truly great nurse.